just want to get your thoughts on this Gilead drug and really just on the race to find some type of cure or vaccine for this COVID-19 crisis, and how much hope you're putting on scientists being able to achieve that.
So first, thank you so much for having me. Secondly, I think, as everyone is aware, there is no real cure for this disease. Part of the problem that healthcare providers across the world are facing is that we have really symptomatic and supportive therapy that we are using to take care of these patients. It's a little early to say that Remdesivir is not effective. I've seen the report, but I have not looked at the data in regard to exactly what the effectiveness of the medication was and where it did not seem to be as effective as compared to other therapies. We do know currently that there is really not an effective cure out there, and certainly we're looking for a vaccine to be available as soon as possible to try and prevent the disease from occurring. But currently, again, I have not seen the data from China, so I would be a little premature for me to comment on exactly where the drug fell short compared to expectations.
Understood. Dr. Weinstein, of course, this was an early trial, the first clinical trial for Remdesivir. Do most of these drugs tend to perform poorly in these initial early trials?
So again, it depends entirely on the cohort of patients that are being treated. Again, we have seen some initial data out of other institutions, including Chicago, that suggested that the medication did have a promising effect. So again, it depends on the cohort of patients being treated, how sick they were on entry,
right,
what the qualifications for the drug were, and what the expectations were in terms of a treatment strategy. So again, I think we need to see that data before we make any determination about really whether it was effective or not. And again, I think this is in contradistinction to some of the data that we saw last week in regard to preliminary results from the data that was coming out of the Chicago centers.
All right, doctor. So let's talk a little bit about some of the current treatment of patients that we have in our hospital systems. I know your company has about 36 hospitals around the country. Based on what you're seeing today here towards the end of April versus what you were seeing maybe back in mid to late March, how has the tactics to treat COVID-19 patients coming into those hospitals, how has that changed? Has it improved? And if so, how?
Sure. So again, I think we've seen a significant improvement in the way that we are treating these patients. First of all, we're using a much more aggressive strategy in terms of identifying these patients. So we're getting rapid testing to identify these patients quickly. We are admitting them and getting them to the intensive care unit whenever their clinical signs begin to show deterioration. We have found that early intervention with using a ventilator is a very effective strategy. Many people have suggested it, and we have found, again, that using non-invasive ventilation or waiting for prolonged periods of time before placing a patient on the ventilator is not an effective strategy, and we concur that early intervention, early intubation seems to be really the way to go. One of the things that we've also found is that using additional forms of the therapy on the ventilator, such as using positive end expiratory pressure, also known as PEEP, or low-pressure ventilation, is also a very effective strategy and tends to get these patients to have better outcomes. And finally, we're using a strategy known as phoning, or placing the patient on their stomach to try and recruit as much lung tissue as we possibly can. That also has been a very effective strategy. And as we have seen a lot of these patients in our Massachusetts hospitals, we've expanded our intensive care unit capacity aggressively to try and take care of these patients and get as many of these patients that form of therapy as we can.
Right, really effectively putting in some best practices. Dr. Weinstein, we learned this week that in the U.S., the first death was a lot earlier than people had thought. It was back in February, early February in Santa Clara, California. How does that change the way that you think about the spread of the disease, the scale of the infection of the disease?
So I think one of the things that we're all obviously learning is that there are some people that are very symptomatic with this disease. Those are the patients that we're obviously seeing in the hospital and in our intensive care units. There's another cohort of patients that are minimally symptomatic or frankly asymptomatic, but still capable of spreading this disease. As we look at, the spectrum of this disease, we know that some patients traveled from China to the United States. We identified those patients, early on in the course of the disease. Many people thought that this would be identified and we could basically isolate these patients to try and prevent the spread of the disease. But it's become very apparent that that strategy wasn't very effective and that these patients clearly were able to disseminate the disease. They were vectors of the disease, if you would, and the virus was able to spread from person to person. I think what we're saying today is that clearly the time frame for the disease is much earlier than we had thought. And, for example, the outbreak in Louisiana probably ties back to Mardi Gras and ties back to the fact that people were carrying the disease and were able to transmit the disease earlier on than we had initially thought.